Nice to be there. Okay, well, good morning, everyone, and welcome to our Thursday HIV Center Grand Rounds. As always, let me make announcements for our March Grand Rounds. On March 3rd, we have a double billing. We have Christina Avadian talking about confidentiality counts, parental notification laws, and HIV testing among US adolescents. And the second part on March 3rd will be Anthony Santoro, Environmental and Genetic Influences of Cognitive Functioning in Thai Adolescents and Young Adults with Perinatally Acquired HIV, a pilot study. On March 24th, we have Scott Latendre, Complex Cognition, the Influence of HIV and Comorbid Diseases on Brain Biotypes. And then remind everyone, we've told you to hold this date, March 31st, we have a special event, which is our first Zena Stain commemorative rounds. And we'll have a panel of friends and leaders in the field doing our commemoration to Zena, who we lost a few months ago. Okay, so let me move on to introducing today's speaker. And thank you so much for being here with us. Monica Gandhi is an infectious disease doctor, professor of medicine, and associate chief in the Division of HIV, Infectious Diseases, and Global Medicine at the University of California, San Francisco. She's also director of the UCSF Center for AIDS Research, their CFAR, and the medical director of the HIV clinic. Many of us know it as Ward 86 at San Francisco General Hospital. Her research focuses on HIV in women and adherence measurement and HIV treatment and prevention, and most recently on how to mitigate the COVID-19 pandemic. You know, I don't always get into people's educational background, but in the case of Monica, I just think it's very interesting to point out, it's a reflection of who she is, that she got her BS from the University of Utah with a major in molecular biology and minors in chemistry, mathematics, and also a certificate in British literature from Cambridge. She got her MD at Harvard. She was a resident at UCSF. And during all that, she also got an MPH in epidemiology and biostatistics from Berkeley. And I think it's a real reflection of the breadth of her expertise. She's an innovator and leader in the field, in adherence technologies, among many other things. She's got too many awards and honors and a leadership to the IAS and other international conferences and venues that I'm not going to list them all. But you know, just to point out, many of you probably have been seeing her lately on TV news programs as a respected expert in infectious diseases, including HIV and COVID, of course. And, and Monica, I don't mind saying this, you know, like whenever I see you on TV, you know, CNN or wherever, nightly news, I kind of wave at you and say, hi, Monica. And if someone's in the room with me, I'm like like a kid in elementary school. I say, that's Monica, I know her. So,
oh, hopefully COVID's getting better.
So anyway, you know, your expertise is really respected. So thank you for being with us today. And again, especially on, you know, being early for you on the West Coast. And I will turn the podium over to you.
Well, thank you so much for that incredibly kind introduction. And also just for the honor of being here. I love Columbia. I really do. There was this dream that I had always of going there. So I wanted to talk about adherence metrics for HIV treatment and prevention. And actually, we're going to go over a range of them, though our lab has been working on specific ones. But remember, this one important thing when we think about HIV is that adherence, we are not the only ones who struggle with this. So essentially, the World Health Organization has declared that more people worldwide would benefit from efforts to improve medication adherence than even from new medical treatments. Actually, the National Council on Patient Information has called non-adherence America's other drug problem. And beyond that, only 51, you know, we think in HIV that we have these concerns, but only 51% of Americans treated for cardiovascular disease or diabetes are standardly adherent to their therapy. And there is a lot of termination of therapy or statins. And I remember that essentially the Surgeon General, C. Everett Koop, said drugs don't work in patients who don't take them. So really the question is, why are adherence challenges specifically so so high in HIV and in prevention. And this was an interesting study that was just published last year, actually, by Grace McComsey, but among over 200,000 adults treated with ART, the majority did have suboptimal adherence, and 60% adherence less than 90%, 40% adherence less than 80%. And really compared to, single tablet regimens, that helped, but the adherence problems are persistent. And really the barriers are, of course, everything that we identify in our patient populations. There's just forgetting, but then there's just things like changing daily routines. There's depression, substance use, secrecy, feeling sick, far distance to clinic, stockouts. These are very common in resource-limited settings, food insecurity, housing insecurity, mental illness. So many challenges and barriers. But beyond even saying that people have suboptimal adherence, and you would say, well, 90% isn't that bad, and they're suppressed on their viral load, there are reasons to actually want to increase adherence to almost perfect. And the reason is that suboptimal drug exposure, even if you're suppressed, can lead to residual viral replication. Certainly we know, and this is some very good work out of University of Colorado and others, that just having suboptimal adherence, even if it's suppressive, leads to heightened inflammation, which can ultimately lead to more morbidity. And then having intermittent viremia, of course, can be a public health can lead to forward transmission. So there is reason to, even at 90%, try to want to increase your adherence to perfect. So where are we in terms of adherence monitoring in the world of HIV? And, the way I think of it is sort of more objective measures and more subjective measures to assess adherence. And subjective measures is very easy. It's really just asking the patient. But there are limitations from recall bias, of social desirability bias, of self-reported adherence. And pill counts, retrospective questionnaires, self-report diaries, they all are subject to these biases. And then there are the more objective metrics of adherence. And that would include, and we'll talk about a little bit, electronic monitoring and sensor devices. Those are harder. And then pharmacologic measures we'll spend more time on. And things like pharmacy refill data can be actually very objective, but you need a closed system. And beyond that, it measures how often you pick up the medications, but it can't measure medication consumption. So these are the metrics of adherence that we have in the world, ranging from the least objective to the most objective. Of course, the most objective thing you could do is put someone in a room and watch them take their medications, but that's very invasive. But directly observed therapy certainly has been used in MDR-TB and other fields. But starting with self-report at the top, cheap, easy, but the biases we talked about, pill counts and pharmacy refills can't measure actual consumption. HIV RNA levels are an important metric of adherence, but they're not, they can't be as often as we want, actually, unfortunately, in some resource-limited settings. And then electronic monitoring we'll talk about, but the pharmacologic measures is where we're going to spend most of this talk before we get to questions, because this really is the place that has been burgeoning since the PrEP trials. Plasma, urine, saliva, PBMCs, hair, dried blood spots, all of these can be used as matrices to measure drug levels. So they have pros, which are that they're objective, they absolutely measure consumption, but their cons are going to be that they're more expensive and they're more research tools, except for a point of care metric that I'll talk about with urine. Okay, so really the mantra of this talk is actually what gets measured gets managed. And so let's talk about some of these metrics of adherence and what's the data that we have behind them. Well, it really was the PrEP field that launched this, this field of objective adherence monitoring in HIV prevention, and then fundamentally treatment as well, because we all remember the PrEP trials as they were rolling out, and the first one was IPREX in the New England Journal in August of 2010. And we remember that it was 44% reduction in HIV incidence, which seemed good, but it didn't seem like the macaque trials with oral TDF-FTC. And actually when they looked at plasma levels of tenofovir and stratified the analysis of those who had recent exposure, the efficacy was much higher in IPREX. And then going down, Partners PrEP people were in serodiscordant partnerships, so there was more impetus for adherence. TDF and Bangkok tenofovir study showed these levels of reduction in HIV infection. And then there was the surprise of FemPrep and Voice performed in young sexually active women, but they were did not show the efficacy at all, actually. And there were a lot of questions raised, but there were also plasma levels that had been drawn for and kept for to look at creatinine and other things. And the question came down to adherence. So in the in the Voice and FemPrep study, self-report to the medication, whether it was the placebo or in the active arm, these are in the active arms, was very high, 91%. Returned pill counts was very high. But then actually doing objective monitoring, tenofovir detection in plasma showed that there was only a 29% pill taking in the active arm, basically less than 30% in both trials. And this fundamentally was the reason for the lack of efficacy in FemPrep and Voice, but it raised awareness about how important objective adherence monitoring was. And really, since this was starting in 2011, so forth, this really launched 10 years of really good work in adherence monitoring. So how do we adherence monitor using pharmacologic methods? And there really are four, even though urine can be added to the plasma level, and they really range from short-term adherence metrics, starting with plasma and urine, to longer with PBMCs, drug levels in peripheral blood mononuclear cells or dry blood spots, and then even longer in hair, depending on how long the hair is. So let's talk about each of these pharmacologic metrics and pros and cons of each. Plasma levels are easy, and that's its biggest pro. I mean, they were drawn in these clinical trials. They had plasma levels that could go back and look at tenofovir levels. So they're usually readily available, and they were important predictors of efficacy in all those PrEP trials. But the cons of plasma levels are that they can really have a great degree of intra-individual variability, day-to-day variation in one individual, depending on when you last took your dose, what you ate for breakfast that morning, something that you used that morning. There's a lot of intra-individual variability. And that can be a limitation of a single plasma level. And in addition to that, if you know that the next morning your blood level is going to be drawn for adherence, that's subject to white coat adherence or increasing typical drug taking right before a research or clinic visit. So those are the short window of exposure is its main con. Now, drug levels in peripheral blood mononuclear cells actually were used in IPREX and IPREX-LA, but the PBMC levels, though they were nice because they actually measured tenofovir diphosphate and emtricitabine triphosphate, which are longer term metabolites of TDF and FTC. The problem with PBMCs is that they actually are pretty difficult to process and isolate and actually analyze. And so they've gone down in popularity in favor of the dry blood spot, which is easier to collect. And the same thing that you can get intracellular metabolite levels of tenofovir and emtricitabine in dry blood spots, but they're easier to get. Now, one couple of limitations of drug levels in DBS, which is that they must be standardized to hemoglobin counts. So if there is a low hemoglobin, that can make your adherence look low. It fundamentally does involve blood collection, so it is biohazardous, and you do need a cold chain eventually, though they can be stored at room temperature for a while. And then actually they only provide an advantage, at least in terms of the interests of longer term metrics of exposure, if the drug is processed intracellularly. That happens to be true for tenofovir, emtricitabine, islatravir, for example, but that isn't true for dolutegravir or lenacapavir or typical drugs. The DBS level is really the same as the plasma level, so it may be an easier matrix to collect, but you don't get the advantage of a longer term metabolite exposure. And then what about hair levels? And we'll talk about hair levels next. And then we'll actually go to urine levels. So talk about the longer term metric and a shorter term metric. And we've been working on both of these metrics in our lab at UCSF. So the advantage of hair levels is that it really evens out all of this intra-individual variability in day-to-day variability in plasma levels that we showed prior in the prior slide, because it really becomes almost an area under the curve of plasma levels. It's really a cumulative metric of exposure. We have often used the analogy of hemoglobin A1C being a hair level, and then, of course, the day-to-day variation of glucose being like a plasma level. So hemoglobin A1C is very predictive of outcomes because it provides an average level of glucose monitoring. And it was very interesting, actually, 20 years ago, because it was 20 years ago now, looking at hair levels and thinking about this. There was a group in France who had a paper in Annals that looked at hair levels of Indinavir. And so our group got interested in it. But when we actually looked at the history of hair level monitoring, it was really steeped in history and extremely interesting. So for example, hair levels had been often used in forensic analysis. So why did people die? And bodies were dug up and tried to figure out why someone died. And so Napoleon was a very interesting story, because actually his hair levels were looked at after his death, and he had very high levels of arsenic in his hair. And so the theory was that he had been poisoned, and that was his cause of death on Elba. But actually, someone went back 10 years later and washed his hair and found that the hair oils that they were using at the time were full of arsenic. And so after washing the hair, he did not have high levels of arsenic in his hair. And in fact, he couldn't have had those high levels. He would have died much earlier. So because of that, that wasn't his cause of death. But the same thing has happened with, for example, Beethoven, who had lead poisoning, and heavy metals can be detected in hair. Newton had a lot of thallium, mercury, and antimony, just exposure to heavy metals. And other places that hair levels have been used besides the historic forensic interest is in substance use monitoring, has been used to a certain degree in epilepsy and antipsychotic medications, which are often given, often have issues with adherence. And then also looking at exposure to organochlorine pollutants. So this is being used in the environmental field, and then has also been used, for example, looking at stress. Even though these are endogenous cortisol levels, endogenous cortisol and levels in hair can tell us our level of stress. So it's been used in a bunch of different ways, but the field of hair monitoring in HIV medicine started relatively recently. And again, I showed you this idea that hair really is a long-term metric of exposure. It really accumulates, it measures a cumulative drug exposure over weeks to months. And it really depends on the amount of hair that you're analyzing. So essentially, hair grows at about 1 centimeter a month standardly in the back of the head. And so the first centimeter becomes actually a marker of the last 4 weeks of exposure. If you go down to the second centimeter, that was 2 months ago. 3 months ago was your third centimeter. So there is also one advantage of hair monitoring, which is the idea of segmental analysis. Hair is pretty easy to collect. Don't collect it from the back, but where we collect it is really from the head. We actually don't collect it from the axilla or pubic region, because hair grows in those regions in fits and starts, and it doesn't grow steadily, which is a good thing for life. But actually, we need a really place where there's steady hair growth for hair to grow serve as a marker of time. So hair is collected from the back of the head. It's easy to collect. To just take scissors and a piece of tin foil that we wrap it in. And the best part of it is that it's not biohazardous. It's stored at room temperature. It can be shipped at room temperature. So I've gotten many, when we used to do it in person, and hopefully next year again, I used to get many hair samples at Croy. But this really was, it really does have that advantage and that feasibility advantages of not needing a cold chain. We started developing these hair levels in our lab quite a long time ago, but we actually do require a liquid chromatography tandem mass spec machines. And that is where we'll get into the expense later on of this, because it does require these fancy machines to get the hair levels. What we do is actually we shaved the heads of people who were highly adherent to therapy so that we had a lot of hair on the same drug, and then we could optimize our hair assays. They're pulverized, the drug is extracted with a solvent and then injected into this fancy machine, and then you can get a peak and measure the specific drug levels that we measure in nanograms per milligrams, essentially. We work with the Division of AIDS Clinical Pharmacology and Quality Assurance Program to ensure our levels and our methods are both validated, but also peer-reviewed and approved before we put them in, for example, the clinical trial networks for HIV. And we can now measure hair levels of all of these medications. Started out with the older ones, efavirenz, atazanavir, nevirapine, lopinavir, can measure darunavir, raltegravir, dolutegravir, and ritonavir. And then we have measured, we do a lot of tenofovir hair level monitoring for both PrEP and treatment, and also have a hair level test validated for cabotegravir and dapivirine. So some of our earliest studies really showed a pretty linear monotonic relationship between the amount of hair in your, the amount of drug in your hair level with essentially virologic suppression in large treatment cohorts. So even adjusting for everything else, hair levels were the strongest predictor of virologic suppression in multiple cohorts and in the ACTG 5257 trial, for example. And so that really shows the pharmacodynamic relevance of this as a cumulative adherence metric. And importantly, hair levels increase following adherence interventions. So as a surrogate, of course, you'll be doing viral loads, but as a surrogate, if someone has suppressive adherence, but not perfect adherence, following adherence interventions, you can look for increase in hair levels to assess your intervention. And I already intimated about the use of segmental hair analysis and the utility of that. But the idea here is that you can take hair levels of each segment of hair, starting from the proximal region near the scalp. And what that is, the advantage of doing so is, for example, in PrEP seroconversions or PrEP failure, you can see where in time there were lower drug levels that would correspond to lower drug taking and likely the time of PrEP seroconversion. This, I think, has been useful for unraveling several of our PrEP seroconversion cases in PrEP failures, but I think this could also have utility in cabotegravir failures, for example, which is, of course, a long-acting drug given every 8 weeks intramuscularly to try to go back in time and see where there was lower drug exposure, and possibly even in longer-acting agents like lenacapavir. And then in terms of PrEP monitoring, we have looked at tenofovir levels in different hair segments to predict pre-exposure prophylaxis adherence to TDF, FTC, or to TAF FTC. And the advantage of that is that you don't have a viral load to measure for PrEP adherence, of course, because these are people living without HIV. So it's helpful to have an objective adherence metric like the plasma levels. And then we've also shown that hair levels can be associated with toxicity. So this was in the IPREX-OLE study, that the 3 predictors of eventually having renal function decrease on longstanding TDF-FTC was older age, starting out with a lower baseline creatinine clearance, and actually having higher levels of adherence, or having higher hair levels, or essentially more exposure to the agent of tenofovir. So these are really the advantages, but there are some disadvantages. The advantages of hair levels is that it really does grow, interestingly, even in malnutrition and other states, steadily, relatively in the back of the head. It's a long-term metric of exposure. The hair shaft becomes a marker of time. Hair is easy and cheap to collect, no special skills, stored at room temperature, no biohazardous precautions, feasible for resource-limited settings, and not subject to white coat adherence. You can't take the drug the day before and have a good hair level. The cons have really been around acceptability and feasibility of collecting it. We've actually had very high levels of acceptability in most of our trials in sub-Saharan Africa and in Asia, and have done some qualitative work and work with the field staff to increase acceptability. and increase hair level collection. But actually, we've had less success in collecting hair levels from white MSM in some of our ACTG studies or PrEP projects in the United States. So when we work with field staff and with participants, we can get increase in hair level collection, but we've had good success, but it does take work. And I will say that, of course, you can't collect hair levels from people who have no hair on their scalp. So that is a limitation that we can't get around. Okay, so I wanted to turn to the urine monitoring test. And this is really a point of care test that has been developed to look at tenofovir at the point of care in real time, just like a rapid antigen test for pregnancy or for now increasingly, of course, COVID testing, but there are advantages of this and there are disadvantages of this. So to understand why we have not had a point of care long-term metric of exposure. Well, we already talked about it taking a pretty complicated machine, which is not only the processing that it takes from lab personnel, but the expensive liquid chromatography, tandem mass spectrometry machine. And only LC-MS can distinguish between two such similar structures as tenofovir, for example, and then tenofovir diphosphate. So getting a tenofovir diphosphate level even on a red blood spot, will take LC-MS. And there's work, for example, to have a desktop machine or something smaller, but it still does take processing. Urine, of course, is easy because you don't need to do phlebotomy. It's collected at the point of care. But what urine levels are going to tell you is not the intracellular metabolite, but tenofovir itself. So on the other hand, in terms of an advantage, actually plasma levels in all of those PrEP trials that we talked about before were highly predictive of efficacy in all of the PrEP trials. And actually, interestingly, even when people knew in some of the Olay trials, for example, in IPREX Olay, that levels were being collected for adherence monitoring, at least the white coat adherence patterns prior to research visits was not observed. So anything that plasma looked like, it's such a short-term measure, urine is essentially the same. They're basically measure the same short-term metric of exposure, about 1 to 4 days of the last 1 to 4 days of drug taking. And in treatment trials, for example, short and long-term adherence is highly correlated and predictive of virologic suppression. This is work, again, University of Colorado with Jose Castillo-Mencia and others, but they really show that, for example, tenofovir diphosphate is a longer-term metric than emtricitabine triphosphate, but they correlate well. And so if they correlate well, and that this is a relatively good surrogate of patterns of adherence, then what you need for a urine level, or the only reason to develop a urine level, is to have a point of care test, because then you could just do the plasma level. So what's the point? The advantage here is to try to develop something that's real time. So the reason that a point of care test, of course, is so extremely helpful is that you could perform adherence interventions right then and there in the clinic, in the research visit, without waiting for a drug level to come back from your expensive LC-MS machine. So the idea would be that you'd have a point of care pharmacologic adherence assay. You could trigger feedback right there with known efficacy, and also start up interventions like pill boxes, peer support, text messaging, provider counseling, motivational interviewing, cognitive behavioral therapy, any of our known interventions for adherence, that they could be triggered on the spot. So I did want to go back to one study, which is in the VOICE study and also the IPREX Olay study. Even when people were told that their drug levels would be monitored for adherence, there was good qualitative data. This is work by Ariane van Straten and others that showed that people were really interested in this type of drug level monitoring. The kind of comments that were made were, if the results of the blood test came out immediately, then that would really help me. That would tell my results right away, and then I'd be compelled to use the products properly. Someone said, you cannot tell someone you didn't use when the wall is your only witness. It would be useful to tell me the quantity of medications. People have said that after hearing the drug level results, that really wanted to make sure that I take it every day, because why take it at all if it's not effective? So these kind of qualitative work leading up to point of care metrics were very helpful to show why I think a point of care metric was so important. So a point of care test really requires an antibody based test. So you really need an antigen, like HCG in your pregnancy testing, or the antigen of COVID in spike protein or whatever it is for a lateral flow assay to detect COVID. You really do need an antibody that is directed against, for example, tenofovir, if we want to use it for both treatment and prevention, that is highly selective, that only picks up tenofovir. And that's how all the substance use monitoring is done in urine tests, for example. These are all antibody-based lateral flow assays. So the way that we, and our group has developed a urine-based test for tenofovir, but other groups have done this as well. But the way that we developed it is we really had to analyze the structure of tenofovir and try to find epitopes on its structure that would look really different than endogenous DNA nucleotides, because it can't look like adenine, for example. So we had to work with chemists and pharmacologists to try to figure out the right epitopes. And then we actually worked with a company, which has now been taken over by Abbott, to help develop the antibody. What happened is that after the little epitopes were developed, these little haptens were synthesized, then rabbits were immunized with these immunogens, and they were bled monthly to evaluate for these antibodies. And after 6 months, an antibody was actually identified that was very highly selective for tenofovir. And it had to be highly selective. It can't, of course, pick up endogenous nucleotides, but also it had to have high sensitivity and specificity. So the next step after finding the antibody was to compare it against LC-MS levels and also ELISA levels, and then eventually develop this point of care test. And so we did directly observe therapy studies to establish the test cutoffs, to really figure out what is a cutoff that's associated with relatively good adherence, and finally worked with the company and helped develop this lateral flow assay. So now it is available. It looks just like this. Time to results are 2 minutes. And it is accurate compared to LC-MS, compared to ELISA. And we co-own the patent with Abbott, and it is available to any of you on this call for research studies. So this is not marketed yet. Actually, everything became delayed. Abbott also makes the Binax COVID antigen test, and everything became delayed in terms of marketing, but we do have the test available for research studies and research investigations, and I would be happy to collaborate with anyone if they're interested in using the urine-based test in their studies. So we have done several sort of validating studies of the urine test to ensure that it's working as it should. For example, there were old urine samples from the Partners PrEP study, which was, of course, the pivotal trial that I showed you before, that showed the efficacy of TDF-FTC-based PrEP in heterosexual men and women. And so there were lots of urine samples stored in the Partners PrEP study to look at proteinuria and other things from tenofovir. And so we took those plasma levels, did the urine test on them, and showed that urine tenofovir levels in the past, essentially having no urine tenofovir in the past, fundamentally predicted going forward PrEP seroconversion in the clinical trial. The same was shown in the IPREX-Olay study, where there was also urine samples collected that a low tenofovir urine level was associated eventually with seroconversion in IPREX-Olay. We have looked at this test in South Africa specifically to actually try to predict resistance, because I'll actually go ahead to one slide to show you why it's such a useful test for resistance in the HIV treatment world. Essentially, having a ART adherence measure and then HIV viral load, and this is slide credit to Jose Castilla-Mencio, but if HIV viral load is in the rows and ART adherence measures in the columns, you could see that, of course, the perfect outcome is having high adherence and a low viral load. That's the expected outcome. You'd want to get positive feedback for that. But if you have a low ART adherence metric and a suppressed viral load, that will portend a problem in the future. So you'd want to counsel on adherence. And then on the right bottom would be having a low adherence metric and viremia. That's an obvious failure of taking medication. But the important box here is this one on the bottom left, which is having high adherence but viremia. That's a big concern for resistance, that you're taking your medication properly, but that you're not viremic, that you're not suppressed. And that really is what we wanted to look at in these studies in South Africa that I just showed you. So essentially, in patients, we're working with groups in Johannesburg, for example, in patients with virologic failure, the point of care tested 100% sensitivity in predicting resistance. And the urine test was highly correlated with a longer term metric in dried blood spots. So that was good to know in terms of the white coat adherence metric. And so it may be useful in low income settings or lower income settings to triage resistance testing, which is more expensive. Again, if you have a high adherence test and that may trigger for you not only getting a viral load, but fundamentally if that viral load is suppressed, getting resistance testing. And the same thing was shown in a study in Uganda among 140 people, individuals with virologic failure. Those who didn't have resistance had detectable urine, but those who had resistance had detectable urine tenofovir levels. So indicating that taking, of course, the medication could not overcome the resistance. And so we think it'll be a useful sort of triage test for resistance testing. And then finally, this is a study that we're doing in Kenya that just finally has been fully enrolled, but this is to look at the use of the urine adherence test for PrEP monitoring and for PrEP feedback. So these are women in Kenya who are actually in non-serodiscordant partnerships, because serodiscordant partnerships is associated with better adherence, like in the Partners PrEP trial. And so the women are randomized to just a standard of care arm or getting the urine test every 3 months and getting feedback on the urine test every 3 months. And then fundamentally, because it's a small study, and I don't think we're going to have, hopefully not very many PrEP seroconversions, the effectiveness outcome is going to be looking at hair tenofovir levels to see if the hair tenofovir levels increase with frequent adherence monitoring with the urine test and feedback to that urine test. And then we are looking at one other major study. This is in conjunction with the CDC in Namibia. And this is looking at a treatment trial, which is looking for urine tests being introduced to 20 HIV clinics to allow for monthly adherence checks. And the goal would be to help, again, triage viral load and resistance testing. And then I'm going to end with some very interesting and other ways to monitor for adherence that are not pharmacologic. I think many of us are familiar with the MEMS caps monitoring. This is really a way to assess every time you open a pill bottle using a medication electronic monitoring system. And though often the older MEMS caps models didn't have downloading capability centrally, now they're really linked to like the Wise pill, for example. They have a wireless chip, so that is automatically recorded when you open the bottle. MEMS caps have been shown to really trigger real-time reminders for people for drug taking. But one problem is, of course, you don't have to take the medication even if you open the bottle. And so these MEMS caps can't serve as a surrogate for actual pill consumption like pharmacologic measures can. And then another very interesting field of research and investigation are sensors and tagans. Tagans are really when the drug itself is marked with an inert detectable tagant. And then when you swallow it, the adherence to the medication can be measured, for example, through a breath test or through a test with a sensor, for example, on the skin. And so that's an interesting idea where you again link it with a tagant and then sense it electronically or in some other way. And this, of course, would be probably not standardly used in clinical care, but more of a research tool. So in conclusion, I hope I've told you about the very exciting fields of adherence monitoring in both HIV treatment and prevention. I do think that it was really the PrEP trials that gave us the idea that we needed pharmacologic measures. Hair is certainly the best metric if you want the longest metric in terms of duration of exposure, and plasma and urine are short-term metrics, but there are other novel adherence metrics in the works. Hair levels are advantageous because they measure long-term adherence, and segmental analysis can be very interesting in using, for example, long-term methods of treatment and prevention, but they are expensive. They're not point of care. And urine levels have the disadvantage of being a short-term metric, but they are advantageous that they are short-term, that there's now a point of care method available. And I really think that to get patterns of adherence, you need a combination of long and short-term metrics. So I will end there so that we have plenty of time for questions and discussion.
Thanks so much, Monica. That was a wonderful presentation. A reminder to everyone, if you have a question for Dr. Gandhi, you can either raise your hand and I'll unmute you, or you can enter your question directly in the chat and I'll read it out. Bob?
Yeah, thank you. Thank you, Monica. That was really fantastic. There was so much good information there. You made really great points about the use of advantages of point of care, and if this is really going to be useful in clinical settings, the need for that. Can you share with us what you know about advances that may or may not be happening in terms of some of these things? Like I know Pete Anderson, I think, was trying to develop a point of care of his assay, and I don't know who, what's your projection in terms of point of care becoming available in the near future for us to use?
Yes, so you're right that Pete Anderson is working on a point of care longer term metric, but it does actually involve a desktop LC-MS machine. That's what his R01's on. And it's exciting, but it's still going to take that work to process the DBS and use this desktop machine. So even though I think it's intriguing, the most point of care metric you can get is this urine test. But the issue with the urine test that he doesn't have is that he's going to be looking at tenofovir diphosphate levels. And even if it takes like an hour, that is really useful to have a longer term metric of adherence at that point of care. But the urine level has that advantage that it's right then and there, and you need no trained personnel. Angela Kashuba was working on this very kind of fancy in situ hybridization, essentially looking at drug levels in hair using kind of real-time metrics, but it also involves a very fancy machine. So the more complex you get in terms of long-term metrics, the harder it is to make it easy. And these urine levels these urine tests are available. We have this test for research. There is a company that's made one. I think everything's been set back by the COVID pandemic in terms of true marketing, but I at least for anyone who wants to do a research study, just write me.
Great, thank you.
Claude, let me unmute you. Go ahead, Claude.
Hi, thank you so much. That was really a fabulous overview and actually very timely for me. I have to write a paragraph. This will be very
I'll send you the talk.
No, that's great. Thank you. So my question, you've sort of gotten at some of this, but what I found exciting about the urine point of care is that it really also can be used for an intervention, which of course DBS has also, but ultimately in the end, adherence has been our Achilles heel, no matter what,
right.
No matter what, and it's hard not to be a little bit, what's the word? I worry that it's just a very hard thing for us ever to get. And so when the metrics are so costly,
right.
even for a research study, do you have thoughts about maybe even where the field can go using some of this so that all of those clinics in Uganda and Kenya and other Namibia countries, and even our country without a lot of resources in many contexts, can begin to implement some of this for interventions, even in conjunction with some of those other CBT messaging tools that you put out there? Yeah.
Yes, I mean, it is actually, we worked in hair for so many years, like 15 years. And then someone just said to me, it was actually my division chief. They're like, yeah, what are you doing? Like, this is not like, you can't do this at the point of care. You need to come up with something like more point of care. And that actually was not easy, this urine test, because getting an antibody, unfortunately, in academia, we are not good at developing lateral flow assays, or at least not at UCSF. Like there is, it does take sort of the high, I don't know, like the kind of money that industry has. And so it was hard to find the antibody, but once you've done it and you've developed it with a company, the question is, can we develop those kind of antibodies for other drugs, for example? So I'm really interested in like an antibody lateral flow assay for cabotegravir, for example, or lenacapavir, because these are going to be these long-acting medications. And I don't know if you all watched the HB-10-083 unblinded results yesterday at CROI, but and Chloe Orkin's really magnificent plenary on long-acting agents. But we're going to have a trade-off with long-acting agents that we're going to have. They're amazing, but if you fail, at least with cabotegravir, you're going to fail with resistance. And the INSTI resistance is really scary. And so if there was a way to point of care monitor, say, oh, wait, your cabotegravir level is not where it should be. Maybe you don't need it every 8 weeks. Maybe you need it every 7 weeks. I think that would be really fascinating. But you're right that the only thing I can tell you is that the urine test is the only one I think it's going to be like less than $1. It should be less than $1 when they market it. It's really easy to make because it can be on a paper strip, like those paper pregnancy tests. Yeah. So anyone who's trying to, I hope they don't, we've already told them that if they want any utility for the product in the WHO guidelines, has to be cheap.
Can I just follow that up? Is this okay, Stephen and Bob, with one other question, which has to do with the meaning of urine testing? Yeah. And I was thinking about how are youth responding to this, but also how are people who have substance use, who are used to being monitored by urine. And I'm just wondering about acceptability on that level.
Interestingly, we actually had that issue more with hair, especially around the time with Britney Spears. Remember when she shaved her head? Like there was some drug thing. And so hair has actually been more, we very much write in the consent, this will never be used for substances. Now urine, you actually point out the converse of it, which is that now we've been starting to use it for substance use monitoring and adherence monitoring with contingency management in people who use substances. So I have a mentee who just put in a K grant where she's going to do contingency management for having lower urine, less methamphetamine in the urine and more tenofovir in the urine. So you can use it in the converse, but you're right. If you are not using this in people who use substances, these urine metrics, you have to reassure them, both in the consent form, if it's a research study, or in the clinical setting, that this won't be used for substance use monitoring. And you're right, it has to be counseling.
There's a message in the, am I muted?
Okay. Yeah, I'm seeing other.
I was actually going to go to Ray Moody first. Ray had his hand up for a while. Ray, go ahead.
Great, thanks. This is fascinating. And I guess I'm wondering, like, I'm thinking about just the urine test and how cheap it is. And I'm thinking about like what Abbott's done with the COVID test and at-home testing. And so you're talking about point of care, but I'm also just thinking about like the consumer end of this, and where you think potentially these urine-based screens could be implemented in treatment particularly for people who are like on intermittent regimens, or like who are like event-driven regimens, like basically like knowing your status, right? Like and like prior to as in decision making and stuff like. And
yes.
Curious about that.
That's a great question. We have thought about it in 3 ways based on what you just said. One is like, could there be urine tests, at a door in a club? You're going to check if someone's on PrEP, and they show you that they have tenofovir in their urine. That would be an interesting research study. Second is there are these grants. I know you all know about the LIGHT grants, which are the ones for, the LIGHT grants through the NIH are really supposed to be recruiting people at risk for HIV on different social media websites and doing everything at home. Everything is sort of remote. And so, for example, someone doing their urine test at home and then showing the investigator on the video that they have tenofovir in their urine could be an interesting way. That has been used in contingency management for substances. And then the third way is in treatment. Could people, like you just said, self-monitor at home? One thing that we've heard qualitatively from the Ugandan setting, at least, is that people really like to see the tenofovir in their urine when you're on treatment, because it just reassures you that the drug you're taking is being processed appropriately and is in your body. So could there be something where, for example, the NIH is going to release RFAs on, they're called LIGHT VS, which are people on treatment who have problems with virologic suppression. And the whole idea is to recruit from online forums and do everything remote again. So could you show, the investigator the test, the urine test? And of course that could be, I guess, subject to tampering, but someone would be in your house would have to take tenofovir to have it. And it's a little harder to tamper with yes, as opposed to substance use, which is no.
Thanks. As I write my K around this subject area, I will probably be reaching out. So
just monica.gandhi@ucsf.edu, and please reach out. In fact, I do think, I'll tell you that putting it in K applications, I think, is a great idea, because at this moment, urine monitoring is still novel. Hair monitoring is getting a little old. But in fact, I used to put, recently someone said it was innovative in a grant, and they're like, no, people have done this. But urine monitoring is still pretty novel. So that would give you innovation points. So I will put my email. Well, anyone can get my email readily.
Yeah, I'll share with you, Ray.
Okay, thanks.
Thanks for your question, Ray. Monica, you're getting plenty of accolades in the chat. Susan Truss has a question. She says, thanks so much. This was an amazing tour of the field. Do you see a role for self-report along with these terrific measures?
Yes, I mean, actually, self-report is as easy as it gets. And it also is the relationship that you have between patient and provider. And so I do think that self-report will always have a role. And, in long-term relationships, people are very, forthright with their adherence patterns. So I think self-report will always have a role. It's just that the reason that it's sort of been interesting to have in a research study urine, plasma, or hair collected is you can go back in time if you have unexpected results from your self-report and go back and use those metrics to verify why you didn't see what you were going to see. So I would say that self-report will always have a role.
Thank you. Any other questions? Mike, yeah, let me unmute you.
Yeah, I want to jump in on just the last point, if I can. And I see that Ivan Balan is here. I don't know if he wants to speak up, but I'm wondering, like, have you seen or have you yourself used these objective measures in conversations with patients or participants in studies to say, okay, in a very kind of, MI kind of way, people who have trouble, we noticed that this, can we talk about it? What might be going on? Have you done that, or you see the utility of that?
Yes, so that PrEP trial in Kenya that I mentioned is supposed to be a motivational interviewing way. We actually show the women the urine test and say, hey, let's talk about like why this is negative. And we did qualitative work prior to this to help develop the way that we counsel. How did women want to get feedback about their test? And they really helped us saying, well, don't tell me that I'm doing something wrong. Life is hard. Just tell me that it's not there and what do you think I should be doing? And so in a non-judgmental way, we developed those kind of motivational interviewing. And again, we've in a way had good success. I will do post-qualitative studies as well on the acceptability, but so far it's been really acceptable because they agreed to be in the study. And in a way, those qualitative studies from Voice really showed us that someone knowing it's in their body or not, it's almost a verification that what you're doing means something. I actually think I have to use this comparison, but I think about it with the COVID vaccine, that somehow people, immunity is invisible and they don't feel like a secure about their COVID vaccine, but it would be a way to like measure T cells and say, look, it works. So, so I think I feel like people have liked it, and we've done qualitative work around that.
No, it's great. Thank you.
I see Mike, who
I think Mike.
Yeah.
Hi, can you hear me?
Yes, hi.
Oh,
Yeah.
Monica, that was fantastic. I want to ask you a little bit more about what you were talking about with the cabotegravir
Yes.
for urine assay. Have you guys explored that? And is some of the difficulty with defining specific epitopes, or is most of the process the process of getting antibodies produced in quantities and production thereafter?
Actually, cabotegravir is going to be pretty easy as compared to tenofovir, because tenofovir is a nucleotide analog, and our TI looks much more like our DNA. And cabotegravir as an integrase inhibitor looks nothing like what we have in our body. So it's going to be easy. Actually, my entire conflict with cabotegravir has to do with the fact that Abbott is just making COVID tests right now. So I need the COVID pandemic to stop or to calm down so that they don't need that. So I'm actually, contact me offline if you're interested. We can explore this together.
Terrific.
I don't think it's going to be difficult to get an antibody to cabotegravir now.
We have a question from Ivan Balan. Go ahead, Ivan.
So thank you for the invitation to jump in on this, Bob and Monica. This is wonderful. So thank you for this great presentation. And I'll jump in on regarding Bob's question of how we share those results with folks. And I agree. It's when we align this process of monitoring adherence to a patient or a participant's goals of remaining HIV negative, it's a very powerful and positive experience. The issue is when this is perceived as we're keeping tabs on what you're doing, and we're going to know if you're not taking your medications.
Right.
So I think that's well established. I love the work that you did on trying, on learning how the women want to be approached about this. That's so important, right? The issue then becomes that this way of thinking is oftentimes a real challenge for some providers who are much more directive and who, in the face of poor adherence, can really become much more confrontational when they see something not going well. Like I even noticed in the counselors that we train. So if adherence is going well and they're sharing some biomarker results, oh, this is all good, right? And they're doing it really beautifully and on. But when adherence isn't as good, now it's a little bit of a struggle. And it's difficult training people to sufficient skill in dealing with these now more sensitive conversations.
I completely agree with that. And that's why, at least in the study setting, and we are really only in the research phase of this because it hasn't been marketed. People are not using it in the clinical setting yet. We would not allow, kind of counseling to occur in the research study without doing the pre-formative qualitative work and developing developing written guides to how the feedback should be provided. So that hopefully then becomes training for the future of how to deliver it in clinical care. But you're absolutely right. Our tendency is a tendency in providers towards judgment is going to be, a limitation of this. And we have to learn motivation, just like we're trying to learn motivation and motivational interviewing and non-judgmental ways of being throughout our entire careers for everything else. So I think it's a great and a really important point is the preparatory work that you have to do.
And if because I think this is a great tool that you've developed. If I can recommend one thing.
Yes, please.
Aside from the written materials, if you can just develop, and do some demonstration videos that can upload it to YouTube, because it's one thing to read something. It's another thing to witness how a conversation varies. There's these great little MI videos on like the effective physician, the non-effective physicians by Lisa Merlo at the University of Florida. And these are like 5-minute videos that shows how people can approach a topic in a much more typical way and how they approach the same topic in a more MI way. And I use them in training all the time. But I think when you can actually see these differences in interaction, you pick up nuances that you don't pick up if you're just reading the materials.
That's an excellent idea. And actually we should quite quickly incorporate that. So thank you so much for that idea. That is excellent.
You're very welcome.
And I will look up the videos from Florida. Thank you.
Mike, did you have another question? I saw that your hand was raised again.
No.
Okay. Any other questions?
I do see the comment, a modified version of directly observed therapy is a feature of New York City's Ryan White Part A medical case management program. So that makes sense. I mean, that is the gold standard. That is as good as it gets, is actually watching people take their medications.
All right, well, if there are no other questions, Bob, I'll turn it back to you.
Sure. Well, just to applause and thank you again, Monica, for I have obviously a lot of people are benefiting from this, and thank you for your generosity and of time. And I think you may be hearing from several of us as we go
I
forward.
hope so, actually, because I think it's a really interesting tool. But the other thing is to likely possibly in prep incorporate a long-term metric so that we do the short term and then have a long-term as our effectiveness outcome. So I can also do the hair levels, or Pete Anderson can do the DBS levels.
Yeah, great. Well, hopefully some great collaborations can come out of this. Thank you again. Thank you, everyone. And see you on March 3rd for our next HIV Center rounds. Take care, everyone. Be well. Thanks.